I want to take some time. This is a snippet and a preview of some really exciting talks to come about liver transplantation, how it's entering the arena for metastatic colorectal cancer. I'm also a surgeon, so continue to be kind. No disclosures. A lot of this background was beautifully presented by Dr. Gulami, but colorectal cancer, obviously the third most common cancer worldwide, 850,000 deaths yearly worldwide. 50% of patients will develop metastases, 25 to 30% synchronous, and 20 to 25% metachronous. The five-year overall survival of metastatic colorectal cancer remains poor, 15%. And 10% of new colorectal cancer diagnoses are in those that are less than 50 years of age. So really, this incidence has been increasing since 1988, but has really come to light recently. And you'll see why that's a bit relevant when we think about the framing of this disease and the treatment options. Just a review, we talked about surgical therapies as the curative therapies, be it resection or transplant. Approximately 20 to 30% of patients with metastatic disease are resection candidates. So really the minority is what we're talking about. And the five-year overall survival was just briefly covered. Systemic therapies, I'm not going to really touch upon in this talk, but suffice it to say, with the biologics have evolved over some time, as well as the liver-directed therapies, which were just presented. When we think about resection or transplant, very simply, you think about things at the patient level, the liver level, and the tumor level. The patient factors are quite simple, and we have to think about this a lot in transplant because, if we're looking for candidates, you have to think about the comorbidities, physical status, psychosocial status, and whether we're really willing to undergo a transplant. The tumor factors are the ones that are most relevant when we talk about transplanting for colorectal liver metastases. And the reason for that is that different than transplanting for other indications, it's more likely that the tumor factors are the limiting actual part of this than actually the liver function in and of itself, because most patients with colorectal liver metastases, their liver functions well, it's just that they have the disease of the cancer there. So the number of lesions, locations, the nodal burden, extrahepatic disease, or the lack of in terms of qualifying for transplant, tumor markers, as well as genetics, as well as ctDNA, response to chemotherapy. So this idea of response to chemotherapy and or LRT is kind of what we go by currently in the field as the best surrogate for who we think would be the best potential candidate for transplantation. The location of the colon primary. With regard to liver factors, chemotoxicity, all of these patients get some degree of chemotherapy, usually first line, some second line in some of the more current trials. Liver volumetry, specifically when we're talking about liver resection, as well as functional assessment. And then the lab meld. The lab meld in these patients is generally quite low. Like I said, they have preserved liver function. So then we think about lab meld in terms of a pathway to getting them to transplant. And so that will be a topic of some of the other upcoming talks. So we know this, resection for higher tumor burden with early recurrence yields a bad outcome. And that outcome is similar to just chemotherapy alone without resection. So putting a patient through resection in that scenario obviously can be challenging. Transplantation remains an option for highly selected individuals. So I'm not too sure I would go so far as to say it's a standard of care, but I do think that it's definitively an option for patients who are very well selected with liver-confined metastases that are unresectable due to tumor burden or underlying liver function. So limited by organ availability, living donation, and some of the new novel perfusion strategies that we have for deceased donors are opportunities for us to increase the pool for where we can transplant these patients from. The idea of transplantation for colorectal liver metastases or liver metastases in general is not a new one. It's what's new is old, what's old is new. In the 1990s, early 1990s, there were initial studies that came out about this, but when you look at the data from back then, the outcomes were dismal. And quite frankly, for that reason, there was a moratorium and people didn't really think about this for the next 10 years. But you can see that, first of all, the 30-day survival post-transplant, there was a mortality of about 20%. And secondly, the majority of patients, ended up succumbing to disease, and it was no different than chemotherapy. A lot has evolved in the field of liver transplant that has changed the outcomes of liver transplant patients in general and our understanding of disease that allows us to better select these patients with better outcomes now. So the first of these trials out of Norway. Norway is an interesting country and has kind of pioneered a lot of the trials in liver transplantation for colorectal liver metastases. because they have a surplus of organs, not a problem faced by many places in the world. Their average wait for transplant is about 30 days. And because of that, they've been able to use liver transplantation for expanded indications, where you could do a maximal resection, an RZR resection in patients that you do not believe have a disease outside of the liver. So the first trial that was published in 2013, spearheaded by Paul Dag from Norway, was a prospective pilot study for unresectable liver-confined metastatic colorectal cancer. The inclusion criteria was quite broad in this trial. So they started and they said, no extrahepatic disease, radical excision of the primary tumor, good performance status, but really there's just a minimum of 6 weeks of chemotherapy. They did a perioperative staging laparotomy, make sure there wasn't local lymphatic spread in the portal lymph nodes, and the initial trial had 21 patients. As you can see, the overall survival, 1 year survival was good, but 5 year survival was limited at about 60% in this group with that selection criteria, and the recurrence rate was 90%. Now, we know from having studied these, and I'll allude to this in the further studies, that these recurrences are different than recurrences after liver resection. And a lot of these recurrences are slow recurrences. They happen in the lung. Those could be treated. They can be resected. And the patients generally do have a better overall survival than when they have recurrence that's in the liver. 7 patients with no evidence of disease, which was quite promising. And the investigators of this study then thought, well, let's add some selection criteria that's a little bit more stringent, that focus on tumor biology. At least 10% response to chemotherapy, time from diagnosis from liver, to liver transplant, more than a year, and the excised primary tumor less than 10 centimeters. 15 patients, and as you can see, the outcomes were actually quite excellent. 5 year survival of 83%, which is what we see in other diseases of the liver that we transplant for. Disease-free survival, there was still recurrence despite increased selection, but obviously the recurrence rates were less. There have subsequently been transplant criteria that have evolved from this. The Oslo score, which has come from this, is restrictive criteria, especially if your score is 1 or 2. But it's basically these parameters are negative predictive values. So if your largest lesion is greater than 5.5 centimeters, CEA levels greater than 80, progression on chemotherapy, or your time from resection of primary tumor to transplant is short. Metabolic tumor volume is another marker that's evolved and now is incorporated in a lot of protocols. And then really the Fong clinical risk score, which was evolved in the setting of resection, has been adapted in the setting of transplant because we've noted that with low scores, you have better outcomes overall. This is a very interesting paper. There's a lot of work that's been done in this, pioneered and kind of pushed forward by Dr. Hernandez Alejandro's group out of Rochester, and they've done a wonderful radiographic pathologic study. And so the first column, theirs is hard to see, but you can at least look at the patterns, is how the patients looked when they presented for evaluation with colorectal liver metastases, and you can see the lesions outlined. The second column there, as you go to the right, is how they were at the time of liver transplant based off of radiographic findings. And the third is the pathologic explant and the location of tumors. And what they noted is that 64% of patients had undiagnosed metastases on explant, accounting for 22 unaccounted viable tumors, and that 57% of patients demonstrating complete radiographic response to Ahmed's point with the HCC had viable carcinoma on an explant in the colorectal liver metastases setting. So, these studies have, these findings have been validated on meta-analysis now with over 400 patients. And these patients tend to do very well when they do survive. But obviously, this survival has been somewhat limited and is evolving as selection criteria improves. The TransMet data is kind of the most convincing data. There's nothing novel in the findings and the takeaways from the TransMet study, except to say it was a lot better study and the quality of evidence has now increased. Randomized controlled trial, chemotherapy versus chemotherapy and liver transplant. And I'm going to go quickly over this because we're going to focus an entire session on this on Saturday. But suffice it to say, 94 patients randomized, followed up 59 months. And the punchline is that the 5 year overall survival is 56% versus 12% in the liver transplant plus chemotherapy arm. Progression-free survival is 17 months versus 6 months. And come at Saturday at 2:02 p.m. and you'll learn more about that. I'm going to touch base on some of this. in terms of like the exception criteria and getting these patients transplanted and the living donor talk as well. But I do want to conclude by saying that the transplant oncology indications continue to evolve, specifically not only for solid organ transplant, but for metastases. Liver transplant really should be considered for liver-confined disease. Tumor biology is really king and queen here in terms of us deciding who to transplant. Early referral is important, and multidisciplinary care is extremely kind of the crux of being able to choose the right patients. Thank you very much.